Good morning. I'm Dr. Stites, Chief Medical Officer here at the University of Kansas Health System, and welcome back to Open Mics with Dr. Stites. Hey, one of the best things to come out of the COVID pandemic is the telemedicine revolution. Video visits were a way to reduce the risk of exposure, but more importantly, they're practical, especially for rural or homebound patients. Telemedicine connects patients with care they might otherwise not be able to get. Today, we're going to focus on one part of telemedicine, palliative care, a specialty that has really benefited from this telemedicine revolution. With me now are two palliative care doctors, Dr. Ben Schock, did I do it right?
Perfect.
Not bad, excellent. I did practice once or twice. And Dr. Dr Williamson.
Good morning.
Yeah, that's a lot to say. I'm just going to say KPW. I've been saying the same thing for years, and that's what's going to come out today. Dr. Williamson is also the Medical Director of Palliative Care Services here at the Health System. Aren't you some section leader, division director? What is your full title now?
The Division Director of Palliative Medicine in the Department of Internal Medicine.
There you go. I thought we had made that a division. You got all that officialdom going. Excellent. We'll also hear from a couple of patients in just a moment. Dr. KPW, Dr. Williamson. Let's start with establishing the difference between palliative care and hospice care. A lot of people lump those into the same thing, but we know they're not really the same thing. So help us understand the difference.
Yeah. So, there's similarities and differences. Both hospice and palliative care are team-based care that's focused on quality of life and helping patients and families when they're dealing with serious illness. But the really critical difference is that palliative care can be delivered at any age, at any stage of illness, and can be delivered right alongside curative interventions. Whereas hospice is a part of the healthcare system globally that folks decide to use when they may be coming much closer to the end of life and want to use a different part of the healthcare system, staying at home with loved ones and a team coming to them to assure comfort at home.
So palliative care can be a part of hospice care, or it can be part of pulmonary care, or people with liver disease or heart disease.
Absolutely.
In fact, I think you and I may have worked together a few times on some palliative care on some patients who had some struggles at home, and this helps make people comfortable, even though they're not entering end-of-life decisions.
Correct.
And I think that's one of the things we have to remember. So has telemedicine improved care for your patients?
I think telemedicine has been absolutely revolutionary for our population because these folks have a hard time getting to us, sometimes across hours of the state. And so I've just been blessed to be able to reach patients I would never be able to see otherwise, who wouldn't have access to specialty palliative medicine services.
That's a big deal. And Dr. Schock, do you think it's made a difference for caregivers as well as caregivers? Well, that came out really well. Let's get caregivers.
I think so. It's been really important, for my patient population. Everybody has a cancer diagnosis at one point, or maybe they're going through chemotherapy. And a lot of times, especially during COVID, maybe they've had one family member along with them during visits, and telemedicine has made it possible for people, family members out of state, to be a part of those conversations. And really, if a person is more homebound, not able to get out of the house, it's easier for them and their caregivers to have regular contact with their physician.
And so, which patients do you think benefit the most? Is it somebody kind of at end of life, or is it, which is I guess would be more hospice care, or somebody who needs symptom management and challenges with some discomfort or pain they're having?
Yeah, I think it's person dependent, patient dependent. I think lots of people can benefit. Probably the people that benefit the most. High symptom burden, especially I'm thinking of people with fatigue related to their cancer, or if they get very short of breath even trying to stand up out of a chair. It's been such a service for them to be able to, sit on their couch at home and log on to a telehealth call and get a lot of their questions answered. So I'd say patient dependent, but probably many people can benefit from telemedicine.
So Dr. Williamson, I'm impressed, and that sometimes when I've done these telemedicine visits myself with patients, and you not only see the patient, but you also see them in their home environment, and you learn so much just by that.
Right, yes. I always like to think about our professional relationship, but also learning who these folks are, these patients and their loved ones and their pets. We always spend time, they get to meet my cats if I'm at home. Yeah. I get to meet their dogs.
Oh, she's been part of my telemedicine visit a couple of times.
Yeah.
That's my cat, folks. It's named after a Star Trek character, which if you're a normal visitor or viewer on this show, you'll know that's not surprising to you. Go ahead. Yeah, so I think we have one of Dr. Schock's patients on here, Mark Hulen, and I'm hoping I said that correctly, Mr. Hulen. You're joining us remotely. Good morning. How are you? All right. Now, I am told you've had cancer a few times. Talk to us about your current diagnosis and how are things going?
Okay. Yeah, I've had cancer 3 times starting 2019, ending the end of 22. And be quite honest with you, I mean, right now I'm doing great. I think I'm about a year and a half out from a clear scan. So very happy about that.
No, that is great news. But can I just say, most people think cancer 1 time is enough. You've had it 3 times. That's like
yes.
triple more than enough, right? So
yes, it was pretty horrible.
Yes, so talk to us about the mental toll of having to hear you be told, well, you have cancer 3 times.
Right. Well, I've never had a panic attack in my life until I sat in that office and heard the word stage 4 come out of my doctor's mouth. I literally caught fire, started sweating, and then to be told I was cured and 3 months later tell me I'm not cured, have to go through that whole thing again, and then again, very exhausting. I thought I would never be in the place that I am now.
Wow. Okay, so talk to us a little bit about what did palliative care mean to you? And I'd like to have you and Dr. Schock kind of carry that part of the dialogue about how did palliative care help him? And Mr. Hulen, tell us how you felt like it helped you.
Well, for me at the time, when I first met Dr. Schock, is I couldn't walk. One of my legs did not work due to all the cancer treatment and things like that, and my pain was off the chart. I would literally sleep with a massager on my back, just in so much pain. And he basically came to the rescue. I didn't have to have my brother or my mother-in-law or sister-in-law or whoever take me to the hospital for all these appointments and calls. I could sit at home and take the call with Dr. Stokes, and he could, we became good friends. I mean, he helped me get through a very, very tough time and get to the point where I am now.
Dr. Schock, talk to us a little bit about what about palliative care helped Mr. Hulen so much.
Yeah, so trying to get into too many specifics, but Mark had pretty complex pain. So, when he had his cancer diagnosed, it sort of showed up in areas that can cause lots of discomfort for people right along his musculoskeletal system. And as he said, he was having a hard time getting around the first time I saw him. And as we were reflecting before we got started, in 4 days will be 3 years, our 3-year anniversary. We saw him on June 25th, 2020. And just to, sort of see him then and just uncomfortable anytime he started to move. I think really where our expertise shined through was, we see people all the time who have really complex pain, complex symptoms, and we were able to really tailor it to Mark to figure out what was helpful. I mean, he had pretty considerable doses of pain medicine at one point, and then I think a big part of our journey together was he just said, I think that's making me not feel as I want to, and so we were able to pivot a little bit and find a different approach to his pain medicine. So really just taking what was plaguing him and trying to help as best we could with our expertise.
Well, Mr. Hulen, thank you. We'll be back with you in a moment, but let's hope that the third time's the charm and that there is no
yes.
fourth time. All right. We've also talked with one of Dr. Porter Williamson's patients. Eugene Jones lives in Liberal down in southwest Kansas. It's a 6-hour drive from Kansas City, and he says that after his own doctor died, he didn't have many options in town.
Liberal has a real shortage of doctors. Most of them are physician assistants, and so it's kind of they're making educated guesses, but they are guesses.
Eugene's wife called telehealth a blessing. Otherwise, she would have to help make a 12-hour trip with Eugene and his heavy oxygen canisters all the way to Kansas City to seek help, and then have to go back. So that's a long haul with somebody who's got a lot of chronic illness, and as a physician who deals in this space a lot as well, it's so difficult to bring people all the way in and then have to go all the way back home. Dr. Williamson, tell us how Eugene has benefited from telehealth with you.
Well, I think the most important thing is that he just has regular access and follow-up, from his palliative care team, Lauren Steinfeld, and she's my nurse, and we see him once a month, in telemedicine clinic. He's able to access medications to help with extreme shortness of breath when he tries to get around his house. And we've also been able to talk about what he expects from his illness over time and what he hopes, from his living, and also what he hopes if there comes a time where he is at the end of his life. And I've told him, he says, well, you're not my last doctor. You're one of my next to last doctors. But so he knows he'll face the end of life at some point, but we get to focus on helping he and Sharon, his wife, just live the best that they can right now.
So guys, talk to me a little bit about when is it appropriate to use palliative care? When should a physician or a patient think, gosh, maybe these guys can help me? And when is it you're just working through your primary care?
I think that's a great question. When we think about palliative medicine and the tenets of palliative care, basic primary palliative care is a skill set that any provider should have for basic pain and symptom management, communication, patient-centered care. When we think about specialty palliative care, it's an extra layer of support underneath the primary providers, when the symptoms are more complex, when there's other complicating factors of comorbidities all getting added together, when there's complications in communication. These are the times where adding palliative medicine to that team approach can help the team and help the patient and family all together.
So, just as a thought, when my wife's saying I'm being a pain in the rear, palliative care is not meant for that one then.
Well, I don't know. We might need to talk about that.
Okay, excellent. All right. So
I'll ask her.
Yeah, no, let's not. 'Cause I'm not sure if there's drugs for that, Dr. Schock. Can you help me out here? Get me out of this hole quickly.
Fresh off the market for that, yeah.
Yeah, okay. So give me some examples of things that you've done, Dr. Schock, that you think, okay, I'm helping a palliative, this person, their primary care doctor or whoever that was treating their disease didn't know as much, and here's one where it's more advanced and I step in. I think our audience needs to better understand what are the techniques we're using to help support people at home to live more comfortably.
Yeah, so I think of complicated symptom burden, and that can be anything, pain or shortness of breath or fatigue. And I think, as Dr. Williamson says, I think most physicians or providers would have kind of those basic, those basic tools in their tool bag to help their patients. But I think especially when it gets complicated, you're having to use more than one type of pain medicine or just medicines that people aren't really comfortable prescribing. I think that's kind of our wheelhouse. That's our specialty, is getting creative and helping find medications that help people live their best life as they go through their whatever their serious illness might be.
Yeah, so it's medication management, it may be some lifestyle modification or changes, it may be physical therapy. I mean, there are a lot of different ways to help improve patient symptoms at home. Doctor?
Yeah, I think, we tend to look at symptoms, the physical symptoms, but then also there's an overlay of what is the meaning of that pain? How do these symptoms, how does this diagnosis change my identity as a human being, change my interaction professionally with the world, change my role in my family? And then so all of these things that can complicate how someone's living or suffering from an illness. So, yeah.
Everything and above, and I think that there's a lot of psychological support counseling that comes along with palliative care. Is
Yeah.
that fair?
Yes, and I think to highlight just the importance of our teamwork together, we see the patients in clinic. We may have phone calls, but our nurses are on the phone with the patients and families on a regular basis, and they're able to provide support between our visits that's just absolutely priceless.
Well, and I think people with chronic disease need that. As you know, I work with an amazing nurse, and she is on the phone, nurse practitioner, and she was on the phone frequently with patients. And I'm not sure what's a telemedicine visit sometimes, what's a phone visit. I think a lot of times that can be the same thing. You can deliver so many services the same. Okay, Dr. Williamson, you brought some maps showing where your patients live. Talk to us about what we're seeing here.
Well, so it's kind of hard to see, but we have taken a little snapshot of the patients we see in person and in telehealth, to kind of see the differences. And there's a different map that I didn't manage to get in here, but the first one here is a combination where we're seeing these people in person, and then we're able to compare patients that we see by telehealth. And there's a different, I don't know if we're going to change, but there's a different distribution that moves away from the metro area to more rural areas, because the folks who live in the metro area are able to get to us more easily than folks who have to travel hours and hours.
So it's about the zip code and where they are. The further away they are, sometimes it's harder to access, and they need that help. And of course, if you're more homebound, then you still need it, even when telemedicine can be great locally too.
Right.
Now, the one challenge can sometimes be that you need a really good internet connection to stream live video. Not everybody has a great internet. Talk to us about that barrier, guys. Dr. Schock.
Yeah. Obviously, broadband helps. I think we've sort of run into some instances where it's just been difficult to make that strong connection. But I would say, for the most part, even in very rural Kansas, we've had people in all four corners of the state. I would say most people are able to get on. Sometimes there's a little bit of a lag, and we have to work through tech issues. But I've been pleasantly surprised with the people in more rural areas who have been able to log on to visits, but absolutely high-speed internet helps facilitate those visits a lot.
Dr. Williamson, you've got a graphic I think you wanted to show about www.broadbandkansas.com. Talk to us about that.
So the Office of Broadband with KDHE is working on mapping people's broadband access across the state so that we can make sure we have really good connections for these visits. And so there's currently an effort to do that mapping. You can click on that link and it will allow you from where you're at, wherever you're at, to test your broadband. And then they're mapping that to help understand gaps and places in the state where our broadband access needs to be improved.
All right, so that's a really big and an important project. Just as a question, what do you do when telemedicine either doesn't work or people aren't quite so tech savvy?
Yep, so I would say at the office where I'm at in Overland Park, our medical assistants, our nurses go above and beyond to try to make sure people have what they need before we set up a telehealth visit. Sometimes we get people in the call and they're having camera issues or microphone issues, and just as early adopters of telemedicine, I think us on the palliative care team have really had a lot of experience, even just navigating, whether it's through chat or trying to troubleshoot, common issues that people encounter. We've learned some tricks along the way, but I definitely think our teams in the outpatient world go above and beyond to help make sure things are set up before we get on telehealth.
Yeah, and just so it's clear to folks, it actually takes just as many people, and it costs us just as much to pull off a telemedicine visit as it does an in-person visit. Well, how can that be? Because it's a team of people who get the telemedicine part of this going. And if you can't get the video part, just phone, okay?
it's okay. We do phone. I think it's acceptable in some circumstances. I much prefer being able to see the people who we're evaluating, because I think, as we've sort of touched on, it just gives us a lot more insight into what's going on with them that day.
Yeah, and then I think you have to weigh it against trying to go ahead and bringing the patient all the way back, but then you encounter all the problems we've already talked about.
Right. You know, there are patients, Eugene and Sharon, his wife included, who just absolutely would not be able to access us at all if it were not for telemedicine services. And so I think the importance just can't be overstated. Our nurses will do tech visits where they're calling, and our social workers as well will call and proctor the patients and families through how to access Zoom, how to get on, how to understand those links, and then to troubleshoot it. They spend quite a bit of time to make sure that our visits are as effective as they can be.
So what happens if you're wrong and like somebody just go, you think, okay, they look a little short of breath, or they're struggling more than I would have thought? What do you do then if you see that on the video?
Yeah, so I think this is why video's most important, because it gives you a good sense of how they're doing. And sometimes you do get unexpected things, like somebody's pain is new or different, or their shortness of breath is much worse. And in those instances, almost always I would suggest they be evaluated in person. Video is great, but it doesn't substitute for somebody being in the room with you. And I would say most commonly, especially for our people in rural communities, that would be, I think you need to be evaluated at either a local clinic or a local emergency room, in an abundance of precaution, making sure they're as safe as possible. You certainly want to keep them safe above everything else.
You bet. Mr. Hulen, are there times you just rather come see your doctor to see Dr. Schock, or are you just okay? Are you okay with having the telemedicine visit most of the time?
Televisit is the way to go. As you can see, I'm in my work attire. There's been numerous appointments where I've simply pulled into a parking lot, done my telehealth visit, and then go right back to work, missing very little bit of time from work, rather than drive 30 minutes each way to see him. In addition, I think I get to spend more time with him this way, and like he was saying before, the psychological effect of talking to somebody, seeing somebody, telling them how you feel that day, what's new, what's old, what's working, what's not working. It's invaluable.
Yeah, I'm with you. I think that we've heard a lot of patients say that, especially when they have to miss work. And do either of you guys think it's harder to communicate on telemedicine, or can you do it just as effectively on telemedicine as you can in a room?
I used to worry that it would be harder to communicate that way, but I actually don't have that sense at all. In fact, we're able to watch each other's faces more closely, and so I think that it's okay. And when somebody is in the comfort of their own home and they're comfortable in their space, that can allow them the freedom to be able to communicate things that might be hard or scared in a sterile hospital type environment.
Telemedicine has just come so darn far, and part of it was the legislation that occurred for the emergency relief around the pandemic. Prior to that, a patient had to be in a medical office, and you had to be in your office to make a telemedicine visit, which to some degree almost defeated the whole purpose, right? Because it took away some of the points you made, Mr. Hulen, about I can pull in a parking lot and do my visit. And I've done the same thing with my primary care physician. I'm driving down the road and in a vacation. Well, I don't have to miss this appointment. I can just do a telemedicine appointment. It's great. And so I think they are really convenient and really helpful. But the legislation changed, because what it had said was you have to be in an office and the patient has to be in an office, and then you can do a telemedicine visit. Otherwise, you can't charge for it. But the reality is you don't need to be in an office as a patient to have a telemedicine visit, and you should be able to do it from anywhere. You recognize it takes a team of people. We still got to get it organized and all that. So it's really not cheaper to do a test. People want to say, well, it must be cheaper. It really isn't cheaper to do one. But the legislation that allowed us, or the act that allowed us to do this from one destination to any other destination, has been really pivotal in the growth. I mean, we used to do about 100 telemedicine visits a day. Now we do about 500 or 600. At the height of pandemic, we were doing all of our visits, which is in the thousands every day. So I think it's settled out. And what I think what we're seeing is, and we're seeing it across the country, is that most places do about 10 to 15% of their visits are telemedicine. I think if you break it down by age generation, what you see in the data is that the patients who are the younger, the 20-somethings and maybe the 30-somethings, are pretty comfortable with technology. They prefer to do the telemedicine visit, especially if they got 4 kids or something out running around their house and trying to solve for that. But on the other hand, some people like to still come in and see the physician. They'd like to be in the clinic, et cetera. And if you're going to have to do other testing like blood work and x-ray, et cetera, it makes a lot of sense to come on in. But for so many people, I think telemedicine can be super effective. All right. We've been answering a lot of questions. We've been talking a lot. We're going to turn our attention over to Alexis Del Cid. We're going to answer your questions. I bet you have some. Send them in to us on YouTube, Facebook, Twitter, email, the Medical News Network. You can use smoke signals. Maybe we'll get that or not, I don't know. But first, we're going to pause to get the COVID count. Dr. Dana Hawkinson has the week off. What I'm going to tell you is we're at a low number of active cases, only 3 active cases. We can celebrate that. I'm going to celebrate it. Total of 13 patients in the hospital with COVID. None are on the ICU, none are on ventilators. That's awesome. But what we have to remember is that it doesn't mean it's over. In fact, what we have to be careful around is wastewater testing is beginning to show a bump in the number of patients who are reporting COVID, or the people who have had COVID, and there may be some increase in symptoms on the rise. And the second thing is this fall, expect to see a new vaccination directed against the XBB. I still don't know who named that. It sounds like a video game. But the XBB 1.16 variant, I think we're going to want to have a little help with that. That one looks a little more contagious and perhaps a little more serious. So I think we're going to be watching for that vaccination to come out and encourage folks to get it. But in the meantime, we're enjoying the low numbers, and man, it would be great if it could stay that way. Hey, let's get some community questions now from Alexis Del Cid. Alexis, how are we doing out there?
We have someone outside checking for smoke signals.
All right, excellent.
The air quality is very poor already, though, so we'll try to limit that. Question from Terry about palliative care. Do most palliative care patients have cancer?
Oh, that's a great question.
It is.
The answer is that any patient who's dealing with a serious illness, can be very appropriate for access to palliative medicine services. And so in terms of our ability to offer those types of services in the hospital, our inpatient consultation team sees every kind of patient in every unit with all sorts of serious illnesses. Our ambulatory offerings for clinics have grown out of the cancer center, and now we're seeing patients who have advanced lung disease, advanced heart disease, Parkinson's, or even working with the young adult population who are transitioning from children's to adult care here at KU.
So I have a question about telehealth. Can I ask
Please.
you? So during
you are allowed to ask questions, even of your own.
So during the pandemic, we heard about teachers who would get a unique insight into the child's home environment, and they might raise a red flag in a way that they wouldn't have seen if they weren't on virtual, seeing the child's bedroom or an adult in the background. Does that ever happen with you as doctors, where you get a really specific insight into a patient that enables you to care for them better, that you never would have had they just been coming to you, because you can see their environment?
Dr. Schock?
Yeah, I think we hit on it just a little bit earlier, but it has been extremely eye-opening just to, go inside people's homes, even if it's just one room, and you can kind of get a sense for what their normal environment is, what their everyday life is like. I think it's helped me gain a better understanding of where, they're coming from when they talk about, I can't make it to an appointment, or I get short of breath from my bed to my bathroom, which is 3 feet away. You really get a sense that, what their normal is. So I'm not sure about, the red flags that you speak of with kids in the home and that sort of thing. I definitely had all 3 of my kids on a telehealth visit once. I hope we didn't raise any red flags there. But yeah, I think it gives a lot of insight for sure into what their normal life is like.
It's funny, in the cystic fibrosis world, I've had a couple of occasions where I saw somebody's home environment, and what I really saw was the food they were eating. And because it was out there, I'm like, how we've been talking about trying to watch your salt content. When I'm looking at what you got there, I'm not so sure that we're communicating well. But no, there are things you see and learn about a patient that are so different if you have a telemedicine. I think it's actually a really great tool for that.
Is that a way you could use it to help get lawmakers to allow you to do more of these? I mean, is that something that could
there's
be
a lot of
different
work
avenue?
that's been done on trying
Yeah.
to, we've been involved in some legislative efforts in Kansas and
Yeah.
nationally that really we're trying to advocate for telemedicine.
Sure.
I think what we're going to find is that, you comment on this, guys,
Mm-hmm.
the device technology has come so far. On your watch, pretty soon you're going to have your oxygen saturation, your blood pressure, your blood sugar, everything will be right here. And then it's like, and your body temperature, you're like, okay, well, that's a pretty good start. What else do I need to get out of this? And you can do so much now. There's even I believe, a home ultrasound device that you'll be able to attach to your iPhone, and you can like look at your heart with it and send me the images. I mean, it's coming so fast so far. So far, so fast. I think I said that wrong. But,
It sounded good.
yeah, well, I don't know.
Sharon has a good question. Sharon wants to know, this is about palliative care. Is older age something that would be considered for palliative care?
You know,
And I don't know if she means just older age or if that would increase your odds of being put in palliative care.
right. You know, I really think that when it comes down to palliative care, it's what are the conditions that that person is living with, you know, and just thinking in general, if somebody is older, just thinking about what matters to them in terms of their quality of life and their living, and if they were to become seriously ill, how would they want the healthcare system, their doctors, their team to approach their care? But just being of older age itself, no.
And maybe the only thing I would add to
Yeah.
comment on this, guys, it's that in general, young people are a little more tech savvy than older folks, and they may have some trouble. 70, 80 years. Like my mother-in-law is I'm not supposed to say her age on the air. She got mad at me for doing that, but she's a little older, and she has some difficulty just managing the tech, and so it gets harder, and there's no one there to help her.
Yeah, we've run into that a couple times. Family members usually step up in that instance. I would just echo Dr. Porter Williamson. I don't think age is a qualifier for palliative care, but a lot of times with age comes more disease, so certainly a lot of our patients are over the age of 65.
One of our viewers just wants to share something. We love when our viewers like to share what they're experiencing. And Ruth Allen, who we hear from time to time, she writes, I use a telehealth with my rheumatologist at the health system, and as long as I'm stable, it works great. I also have my chart to review my blood work, and that's a plus. That is very handy. You get your blood work on my chart quicker than
Really
the
fast.
doctor.
And sometimes you do. It's kind of awesome.
And you can interpret. I have another question. This one is from Janice. This is interesting. Janice writes, once someone is deemed terminal, how long does that mean they have to live?
I'd say it's a tricky question. I've heard it quipped, being human is a terminal condition.
Yeah.
Obviously, in the disease states that we're dealing with, when I think of terminal diagnosis, I think of, as we sort of touched on the beginning, what qualifies a person for hospice care when we start thinking about an end-of-life scenario. And generally, just with those disease states, it would be, if a disease runs its natural course, 6 months or less. Everybody's different. Sometimes people can be on hospice for 6 months, a year, multiple years. It just really depends on that person. But I think in general, if you're told you have a terminal diagnosis, probably in the months to several months range is what people are generally talking about.
Lynn has a question about telehealth. Lynn wants to know, and I think Lynn also wants some clarification, can a patient do their telehealth appointment from anywhere? Do they have to be in an office? Can they be at home? Can they be on vacation and do telehealth?
Dr. Porter Williamson, that's an important question.
That
Let's
is
talk about it. Go ahead.
That is an important question. And so, the current rules are that the patient can be in their home. The important things are where the patient is at and where the doctor is at. The doctor needs to be practicing in a state that they have a license in. So I have licenses both in Kansas and Missouri, so I'm okay on either side of the state line. My patient needs to be in Kansas or Missouri.
Okay. So not vacation wouldn't fly then if they're in
It
Hawaii.
depends on,
And they
right. If that happens, if you're not licensed in the state of Hawaii, that's a challenge.
just got to go to urgent care in Hawaii. Got a question from Bruce. It's a great question. A lot of people have loved ones in nursing homes, and Bruce wants to know, do the palliative care doctors do telehealth visits with patients in nursing homes?
think it's a good question. I have had a couple sort of on a nursing facility, more of the independent living, assisted living. As I mentioned in those instances, often family members show up to kind of help set up tech and those sorts of things. But I think it's happened multiple times, at least in my clinic. I don't know, Karen, if you've had similar.
I've had a few where these are patients that I'm following, and they're at a skilled nursing facility getting rehab, that sort of thing. When it comes to our specific program here in the health system, we don't take we take referrals from our internal partners here, and our clinics are linked to their doctors here at KU. So there's not like an all-comers referral process from nursing homes or just from the community in general. So I'd want to put a caveat that it's pretty patient specific right now.
These are great questions.
All right, well, this has been an outstanding program, and I am so appreciative of everybody being here. And Mr. Hulen, thank you so much. Mark, final thoughts that you might have. What would you want folks to know about your experience with telemedicine and cancer?
Basically that it works. It's very convenient. I was able to talk to doctor and his nurse about all kinds of things, not specifically the pain or not specifically the nausea, and the convenience. When I was doing a little bit better and I was able to go back to work, like I said, being able to pull over, do a telehealth call it is a great thing, and I would hate for it to go away.
I mean, I am right there with you. We may need your help. We're going to keep working on the legislative side of this. We want it to go away as well, or we don't want it to go away as well, sorry, and keep it there. And we really appreciate you being on the program today. And I really do hope you never have to hear that word cancer again, other than accompanied by the word cure or remission or something like that. That'd be great. Dr. Schock, final thoughts.
It was great to see Mark on here today. I guess I would sort of just echo what Dr. Porter Williams said earlier. I was really nervous about telemedicine. Palliative care is traditionally like a high touch field versus a high tech field, and it's really been gratifying, and I think, as Mark says, essential for a lot of our patients who have a hard time getting around to bring care to them and really be patient-centered. So I've been pleasantly surprised, and honestly, I think I hope it's a part of my practice for years to come.
And grows.
Yeah.
Dr. Porter Williamson, final thoughts.
I was gonna just add, Mark's comment about convenience is absolutely spot on. And when I think about it, it's also about equitable access to healthcare. And the palliative medicine specialists most of us are focused on the east side of the state, and we want to be able to see patients all over the state. And so our ability to do that via telemedicine and give everybody the opportunity for the services that they need is critically important, because every Kansan is important, not just the ones in the big cities.
Beautifully said. And also, just to make the point, that even in communities where there may not be as much income or what have you, even here in urban Kansas City, telemedicine can be a great boon for people, because they don't have to leave work. They can take it and they can do this on a break or something like that nature. Or to your point, in rural Kansas, where there just aren't as many providers, and there may be very few or if any palliative care providers, this could be such an important tool. And I think when we think about the pandemic, we think about social isolation, we think about death, we think about all the challenges, we think about the political turmoil. Here's one thing I think we can all agree on. Telemedicine has been one of the most important advances in the last decade. We need to make sure it continues to thrive, because at the end of the day, it helps our patients thrive. We talk all the time about faith, hope, and science. This is something that we can all agree has helped all that and makes us stronger as a healthcare and as a community. Thanks again to our guests, and thanks to our audience. Hey, I think we're gonna have some good stuff coming up tomorrow.
Coming up Friday on the Morning Medical Update. Instant success for a father and son.
I knew it was going to work, but I didn't know it was going to work that well.
I'm Jessica Lovell on the next Morning Medical Update. The quick, easy treatment that can cure tremors, keeping hands steady and giving patients their lives back. Friday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.